Hello, all. As you join, please introduce yourself in the chat with your name. If there are any pronouns that you use, your title and hospital name, so we can welcome each other. So today's ED, syphilis, HIV, and HCV screening program webinar will focus on the key components to creating processes and procedures for a successful ED screening program. Next slide. It is nice to see you all again. I'm Cynthia Rohr, she and her. I am the Bridge Program Director for EDSP. I'm on Ohlone land in Oakland, California. Bridge is part of the Public Health Institute. And as you know, we are so proud to administer EDSP for the California Department of Public Health and for each of you all, the teams who are so critical to this health equity work to reach and connect to care those most disproportionately impacted by this pandemic across California. Next slide. So this session will be led by myself and our partners at CDPH, whose subject matter expertise supports TA on the program. It will include considerations for developing team opt-out culture. We will review electronic health record system and laboratory workflows, and we'll pause briefly for the first of two QAs, and then we'll finish off with syphilis, HIV, and HCV screening algorithms before we wrap up. Webinar attendance, we hope, deeply benefits the EDSP clinical champion and patient navigators. It also meets a program contract participation requirement. And today we also especially welcome lab champions, IT and EHR staff, and others who are supporting implementation of these workflows. Next slide. So let's start off with normalizing a culture of opt-out testing. We seek to build an environment that is welcoming, non-discriminatory, and non-stigmatizing. The goal is for patients to feel safety, respect, and value, and this supports our work to increase their access to care. Over time, we know that exposure to language that reinforces stigma and discrimination negatively affects health and well-being. Biased language may decrease patients' self-efficacy for change. HIV-related stigma, for example, affects prevention, keeps people from getting tested, and impacts disclosure. Next slide. So instead, person-first language treats individuals as whole human beings. It removes language that equates a person to their condition or has negative connotations. And we acknowledge the long activist history of this language, starting with the People First disability rights movement in the 70s. Using person-first language shows that a person is navigating an issue or diagnosis rather than that they are an issue. These terms avoid eliciting negative associations and punitive attitudes, and also individual blame. It's important to note that individual blame erases the role of systemic oppressions that place people at disproportionate chance of acquiring syphilis, HIV, and HCV. Next slide. Thank you. So words matter. Reducing people to a label dismisses their humanity and it sets them apart from others. And we know that certain medical conditions, including STIs, HIV, and hepatitis, are stigmatized more often than others. Some conditions, we are conditioned to see some conditions as moral issues or character flaws instead of the biological diseases that they are. So use clinically accurate, non-stigmatizing terminology the same way we do for any other medical condition. So for example, a person with substance use disorder or a person who injects drugs has a neutral tone and distinguishes that person from their diagnosis, while drug addict does not. The Well Project also guides us to not use infected when referring to a person. Instead, talk about the person. They're a person living with HIV, a person diagnosed with syphilis. We also invite you to leave the term high risk behind. People themselves are not high risk. This is a really common and pervasive term in STI and HIV prevention. And instead, we invite you to refer to people with an increased likelihood or people with an increased chance of acquiring an infection. Clinically accurate discussions can also include a person who does transsexual sex or sex with a barrier or condomless sex with PrEP. All of these examples will be included in the references after the webinar. Next slide. So in addition to a focus on language, normalizing a culture of opt-out testing begins in your physical environment. So our partners at St. Joseph's Medical Center generously share these really awesome examples of their expect the test signage. They have developed these over years of doing screening. So big shout out and thank you to St. Joseph's Medical Center. Notice that they clearly manage patient expectations, address common questions like billing and privacy, and share why testing is important. They also highlight an integrated model of care where screening program partners work closely with their substance use navigator or SEN. Shout out to all the SENs on the call who are now joining us in EDSP and to other services. So next is opt-out testing scripts, which we've talked about a little bit. A culture of opt-out testing is when a patient is notified that testing will be performed unless they opt out or decline testing. I want to really focus on this next point. Separate written consent is not required for any opt-out testing, including HIV testing. A reference in the chat that we'll drop in the chat outlines the 2008 California Health and Safety Code that eliminated HIV test written consent requirements when ordered by a provider. If a person does not refuse the test, then the test can be performed. So you may say, our emergency department screens all individuals getting blood draw for syphilis, HIV, and hepatitis C. Please let us know if you do not want any of these tests today. Is this what people are using so far? Maybe if this is new, I'm hoping that you are practicing with your colleagues, getting the flow of this. If you have another script that you've been working on, please drop it in the chat so you can share with folks. Another option is I recommend screening for syphilis, HIV, and hepatitis C for all my patients. I'd like to order those tests for you today. Any questions or concerns? Okay, so next, let's talk about how to support successful patient outreach. Up-to-date contact information is critical for patient navigators and also potentially for local health department partners to follow up and link patients who test positive to care. So it's really important to first explain to patients that you will need to reach them in case of a positive test result. This is really important context for patients to understand your desire to have multiple ways to reach them, to have backup contact information. It helps you to partner with them. Next, create a process to confirm and document these multiple contact methods. So address, email, phone, a place to leave a message. This might be both at registration and during intake. Perhaps you highlight it in your ED signage. It can be reiterated by the person offering opt-out testing. The important part is that you have a process and that you follow it. So next, partnering and patient outreach is also a really important aspect of this. So your local health department partners may be able to conduct outreach and meet with patients out in the community. This might look like reaching out confidentially on social media, or the local health department and or the navigator leaving a message for the friend or family member whose information the patient shared to ask them to contact the navigator. These details are really important to clarify as you build your collaborative partnerships, MOUs, and workflows with your local health department. This means it's also important to ask patients, particularly those without a consistent address or who are unhoused, for contact information for people who typically know how to reach them. Again, to leave a confidential message to call you. And potentially also addresses where they receive mail, and physical locations where they commonly stay or spend time, so such as on X corner, and where they access services. These may be places that the local health department can't connect with them. Next slide, please. So next is hardwiring training into processes. So first, provide training. There's a reason that in your contract, there is a deliverable for the clinical champion to share educational materials and training opportunities with ED staff about syphilis, HIV, and HCV screening and treatment best practices. This is a critical step to culture change and quality care. And remember that the EDSP resources library, you'll find not just clinical references, but also patient navigator learning modules, patient-facing educational materials that can facilitate these topics for a wide variety of staff. And for the patient navigators, if you're not yet on our Slack channel where the navigators and Bridges, Latoya, Mitchell are sharing and highlighting these resources, please let us know. So next, share the recordings, incorporate information into staff onboarding, and develop goals or benchmarks. As with any clinical change, it is critical to share these and other EDSP progress reports and data at staff meetings, huddles, etc. So next, as we move on to the next section, I will pass off to Ashley, Doctor of the STD Control Branch of the California Department of Public Health.
Thank you so much, Cynthia. I'm excited to be here with folks today to talk a little bit about screening considerations as you're setting up your emergency department screening programs. I am here on behalf and presenting on behalf of Dr. Kathy Jacobson, who is not available, but has prepared content here, and she may join to be able to support some of the Q&A in a moment. So next slide, please. Jumping in, as you all are setting up your screening program, some of you have long time established screening programs. I'm sure when you started, these were some of the questions that were coming up for you all, which is which emergency department patients will be screened. Here are a few different models of opt-out testing that we've seen implemented. The first is universal screening for all emergency department patients. All those who step into the ED will get a screen. The second, which is a very common model, is screening all patients who receive a blood draw in the ED. So pairing that syphilis, HIV, and Hep C test with the blood draw. And a third is screening priority populations. That might be, for example, individuals experiencing homelessness, individuals who are pregnant, people who inject drugs, whatever that priority population might be for your setting. I'll mention, not listed here on the slide, some folks consider starting screening people who are getting tested for other STIs as a way to start their testing program and then ramp up to one of these other models. So that's something we've seen as an incremental approach to setting up programs. Next slide, please. So how often should patients be screened is another really critical question that comes up for folks. The U.S. Preventive Services Task Force, or USPSTF, recommends on frequency of routine testing, which can help guide emergency departments, but there is no consensus from USPSTF, CDC, or other entities on the frequency of routine screening. Most emergency departments have to make a decision based on local incidence and population at risk. And implementing an EHR screening algorithm that identifies folks in part based on the last available test in the EHR system can help simplify identification of individuals for screening. And I want to note here that there's a summary of HIV, Hep C, and syphilis screening recommendations and considerations for ED setting on Bridges' FAQ page. Likewise, each emergency department has to make its own decision about what age to begin screening. Some emergency departments conduct opt-out testing among all patients 12 years of age and older, and that California law allows minors 12 years of age and older to consent to preventative services for STIs and diagnosis and treatment for reportable communicable diseases. Other emergency departments may choose to test only over the age of 18. We recommend selecting an age that will identify the most individuals infected in your community. And I think this is a great opportunity to just press pause, because there's a lot of folks on the line who are longstanding programs who have been implementing testing. If you feel comfortable, feel free to drop in the chat what age that you conduct testing in and any sort of frequency that you select for your emergency department. We'd love to hear what's happening out there in the field. And it sounds like Dr. Jacobson may be on the line. Kathy, are you on?
I am on, sorry. I just realized I'm not on mute, but yeah, so I'll just add here that some EDs will start at age 12 or 13, and others feel more comfortable starting at age 18. Obviously, we know that 50% of STIs occur between the ages of 15 and 24. So it's valuable to start younger, but we let you choose what you feel most comfortable with as far as age that you want to begin screening.
Great. Thank you, Dr. Jacobson. I'll go ahead and continue on to the next slide, and Dr. Jacobson, please chime in here as well. So looking at syphilis screening recommendations, USPSTF issued a grade A recommendation for screening those with increased likelihood of acquiring syphilis infection. Optimal screening frequency for those with increased likelihood of acquiring is not well established. Men who have sex with men and or persons living with HIV may benefit from screening at least annually or more frequently. For example, every 3 to 6 months, if they continue to be at increased chance of acquiring. And also screening pregnant people at the first prenatal visit, with additional screening in the 3rd trimester and at delivery, except for those with a low likelihood of acquiring syphilis that have a documented 3rd trimester negative screen. Next slide, please. In December of 2020, the California Department of Public Health released expanded syphilis screening recommendations for the prevention of congenital syphilis, which included expanded prenatal screening twice for all pregnant patients and screening at delivery. It also included a recommendation for emergency department providers that are located in local health departments or LHDs with high congenital syphilis morbidity consider confirming the syphilis status of all pregnant patients prior to discharge. And this would be via documented test results during pregnancy or a syphilis test in the ED. Also, some recommendations around anyone entering an adult correctional facility who is or can become pregnant to be screened for syphilis at intake. And some additional recommendations for all sexually active people who could become pregnant, getting a once lifetime syphilis screen, additional screening for those at increased likelihood of acquiring, and a syphilis screening at the time of each HIV test, so co-screening.
Yeah, and Ashley, I'll jump in here for a moment and just let folks know we are in the process of reviewing these current screening guidelines, and we may expand them a bit, but we're reviewing them. So once we do revise them officially, we'll bring them all to your attention. And in fact, we're going to be running one of these guidelines that are associated with emergency rooms. We've come up with an alternative guideline that we'll share at our community of practice and get feedback from all of you on that particular recommendation. Otherwise, just really re-emphasizing here the recommendation for screening at any first prenatal visit, even if that first prenatal visit is in the emergency room. During the 3rd trimester, early 3rd trimester, the CDC says 28 weeks. We do 28 to 32 weeks, but earlier is better because treating during pregnancy ideally happens before or beyond 30 days prior to delivery. So 31 days or more prior to delivery. And also, I just want to thank Ashley who jumped in here. I got caught on a tarmac. So Ashley, I'll let you finish walking through these slides. I'll jump in at probably after each one, and then I'll do the algorithms at the end.
Thank you so much, Kathy. Okay, next slide, please. Continuing with screening recommendations, we'll talk about HIV screening recommendations. USPSTF issued a grade A recommendation for screening in adolescents and adults, 15 to 65 years of age. Repeat screening for persons at increased likelihood of acquiring, for example, men who have sex with men, persons with greater than one new sex partner, a sex partner living with HIV or unknown status, persons who inject drugs, and people who do transactional sex work. Also, one-time screening for all pregnant people and third trimester screening for those with increased chance of acquiring HIV. And there's insufficient evidence to determine optimal repeat screening intervals. And just a note here that CDC recommends considering screening MSM every 3 to 6 months, depending on the patient's relevant chance of acquiring, local HIV prevalence, and local policies.
Yeah, and I'll just jump in here. Unfortunately, nobody really knows what the right frequency of testing is for HIV and, for that matter, syphilis and Hep C. So I think, within your ED, you can come up with what frequency you think makes sense, recognizing when tests may be falsely negative, such as we talked about with the HIV test, which can take 10 to 21 days to become positive, and then looking at who are your high-risk individuals that may need more frequent screening than a lower risk individual.
Great. Thank you, Dr. Jacobson. And now rounding out with Hep C screening recommendations, USPSTF issued grade B recommendations for screening in adults 18 to 79 years. Most adults need to be screened only once, and CDC recommends that all adults over 18 receive screening at least once in their lifetime. Persons with continued increased chance for acquiring Hep C, for example, people who inject drugs, should be screened periodically, although there's limited information about that specific interval at which that should occur. An annual screening for men who have sex with men, or MSM, living with HIV or on HIV pre-exposure prophylaxis or PrEP, with more frequent screening depending on sexual or drug use practices. And all pregnant people should be screened for HCV during each pregnancy, except in settings where the prevalence of Hep C is very low.
Yeah, and I don't have anything more to add to this beyond just recognizing that in individuals who have recently been exposed, it is possible for them to be antibody negative and viral load positive. And the timeline for that, if you look at the Hep C guidance, is up to 6 months. And so in those individuals who you have high suspicion, meaning they have abnormal transaminases and they have a potential risk factor in the last 6 months, then those individuals you may want to add a viral load if their antibody comes back negative, to confirm that they are in fact negative.
Great, and now talking a little bit about electronic health record best practices to support your screening programs. Next slide, please. So algorithms which will help can be programmed into your EHR, which will help determine eligible patients within the system. Alerts, which can help alert a clinician to provide routine screening recommendation to a patient. This could be linked to labs like CBC or ChemPanel, history of screening in the last whatever time period, remain increased chance of transmission, and or pregnant as an example. And then automated ordering, also sometimes referred to as smart sets, which automatically populate lab orders.
And maybe just to jump in here, the difference between lab ordering being provider driven versus EMR driven can be significant. To share some general data from back at LA County USC, when we did provider driven screening and did really walking from room to room and offering patients screening via a tester, we would screen between 500 and 700 individuals. When we put it in the EMR, that went up to 3,000 to 3,500 individuals on a monthly basis. So significant increase in individuals that will get screened if you make it EMR based.
Next slide, please. And a note on laboratory best practices. Next slide, thank you. So it's really critical when you're establishing your screening program to work closely with your lab stakeholders. I'm hoping we have some lab stakeholders on the call here today. It's important to determine what is possible in your setting. So looking at ideal testing turnaround time. The ideal testing turnaround time occurs while the patients are still in the emergency department to facilitate immediate treatment and linkage to care. And a note about lab infrastructure, that newer generation lab-based machines can perform all 3 tests, HIV, Hep C, and syphilis, in less than an hour. And an important note about reflex confirmatory testing for any reactive test, this should be performed automatically. And that way, we don't have folks sort of leaving the emergency department needing another blood draw for their confirmatory testing. Dr. Jacobson, anything to add here?
No, okay, yeah, I guess I do. Sorry, everyone. I just got off a plane that was supposed to deboard an hour ago and deborted 10 minutes ago, so I apologize. But what I would add here is that the Abbott Architect can do the turnaround time in less than an hour of HIV, syphilis, and Hep C tests. So most not emergency departments, but labs now have that particular architect. Some have another architect whose name I do not know, which can do the same. And so we encourage you to, if you have these in your lab, to work with your lab to have your tests turned around while patients are still in the ED. And it can all be done on a single tube of blood.
Great. And now I think we're at our first Q&A session, which I think, Kathy, it'd be great to have you to hear if folks have any questions. I think go ahead and drop them in the chat or come off mute. I think we have a couple minutes for Q&A here.
Adam, I see you're asking a question. Do you want to just
I can read that, Dr. Jacobson, but
Sure.
Thank you. So I see here one of our ED providers has expressed that patients have to be asked if they want the test before it can be ordered, and that no billing can be done for these tests. Could we speak to that?
Yeah, definitely. So what we're recommending is to utilize opt-out testing. What opt-out testing means is that you let the patient know that that you routinely screen everyone. Let's say if you do lab-based testing and you do it for folks that do a CBC or a chem panel, that those individuals are going to get tested, then you have a routine script. And I believe there was a script early on in this slide deck that says, we screen everyone for HIV, Hep C, and syphilis who are getting CBC tests or who are getting blood work. Please let us know if you don't want those tests performed. And unless the individual tells you they don't want them, you are free to go ahead and do those tests. You don't need any written informed consent. You don't need any specific individual saying, yes, I want those tests, because that's no longer opt-out. So opt-out is you let them know you're doing the test and tell them that if for any reason they don't want the test, to let you know. And so hopefully that answers the first part of that question. Then the second part of the question is that you are able to bill insurance. If your patients have insurance, you can bill them for these tests. In addition to that, if you have uninsured individuals, that this funding can be used to help offset the cost of tests that were performed on individuals that don't have insurance. other questions, Cynthia?
Thank you. And I also put the reference of the California Health and Safety Code about written consent not being required that we talked about earlier, I think before the chat was working. We'll read Dr. White's question or comment. TAT for HIV reactive test is considerably longer because reactive run in duplicate, which may influence availability of a positive result or reactive result.
Yeah, so and Doug, I don't know if you all have done this at Highland, but what we ended up doing, at least at LA County, and I think some other EDs have done this as well, is when that initial reactive test came back, there was some signal that was put in the EMR that let the provider know that potentially this test is reactive and it's being run a second time. So what Doug is saying is that for the antigen antibody test, the recommendation is you run it once in the lab. If that comes back positive, you repeat it a second time and confirm that it comes back positive a second time. Those are the lab algorithms typically. And each of those runs takes roughly 45 minutes. And so what we came up with was just to put some kind of signal. I think they changed the color of the pending result from like black to red. So providers knew that that person was likely going to come back with a positive test, but the second run test had not yet been completed. I don't know, Doug, if you all have done other ways of indicating to providers that this is likely going to come back positive. But each of those can be run in about 45 minutes.
Okay, so perhaps this will be our last question for this Q&A section. Dr. Jacobson, can you please give an idea from the example you shared about going to opt-out testing and numbers went up significantly? So that was the awesome data that you talked about earlier of going from manual or provider-driven to automated EHR-driven from around 500 to 700 individuals per month to up to 3,000 or 3,500, I believe you said. Do you know in that case what the percentage of positives may have been for LA County USC at that time?
I believe, of course, you know what, I think I would be better to go back and try to dig up that information and we can email it out. But
Sounds good.
yeah, it's been a few years.
For sure. And if other folks from other sites who've already implemented some types of routine opt-out screening can share their positivity numbers in the chat as we move forward, that would be fantastic information here too. So
and actually, Cynthia, if you don't mind me cutting you off
please.
here for a moment, Doug, why don't you remember the manuscript that you and I worked on together with Bernie Branson? Maybe you could put a link to that in the chat for everybody, because I think we did have our positivity rates as well as percentage acute within those positivity rates. And that was a summary of, it was either 8 or 9 emergency departments across the country that we came together and wrote a manuscript about doing HIV screening, and Doug was the lead author.
Wonderful. And I know that's in our references as well. Okay, so let's move on. Dr. Jacobson, I'm going to officially pass off to you and note that you are the chief of the STD control branch at the California Department of Public Health. I know folks have met you previously in our webinars. So I'll pass back off to you to discuss the screening algorithms.
Yeah, and Cynthia, I know you don't want me to say this, but I am going to say this.
Oh, please, please don't actually. So I will mention this. We have gone over this topic at a community of practice. So we just want to acknowledge that. And we hope that folks all benefit from the ongoing discussion and can share what you're doing and share your questions as well that we'll wrap up with at the end.
And certainly feel free if you've got other things you need to do and you know this well to multitask. I will not be offended. Okay, so we're just going to repeat the screening algorithms that we discussed in the community of practice, starting first with talking about syphilis screening and the fact that syphilis testing requires 2 tests to confirm that someone in fact has syphilis, and those are considered a TREP and a non-TREP test. Although I will just say that there were recent syphilis screening guidelines that came out from the CDC that are quite lengthy, about 80 pages long. But one of the sort of key points from those guidelines that just came out is that we've historically said it's a TREP and a non-TREP test, but that the non-TREP terminology may be a misnomer. Just letting you know that, but I'm going to still use those terminologies because it's just easier to understand. So the non-TREP test is either an RPR or a VDRL, and those are quantitative tests that allow for the assessment of disease burden and also to follow your treatment adequacy. And they're non-specific. They can be positive in patients with other conditions. Particularly, we've seen positives in people with HIV and with rheumatoid arthritis. Those are 2 places where you can get a falsely positive RPR. The TREP tests are the antibody tests, and there's a number of different TREP tests, which you can see listed here. Often the one most commonly used in the emergency department is the TPA. But there is TPPA, TPHA, FTA, ABS, EIA, CIA, and TPA. And these are antibodies specific to T. pallidum. And these antibodies usually stay positive for life after an initial infection, and they're not quantitative. We can't use them to follow disease burden or treatment outcomes. Next slide. And these are the same syphilis screening algorithms we talked about previously. The traditional screening algorithm, which begins with the RPR or VDRL. And then if that is reactive, then you move to the treponil test or the TREP test, which often is the TPPA at this point in the traditional screening algorithm. And then if that's reactive, then you've confirmed that individual either has current syphilis infection or previous syphilis infection. And then you need to really do a good clinical history and physical exam to try to help determine whether this is a current or previous infection, whether or not the individual, if it's a previous infection, was the individual appropriately treated previously, or do you need to maybe restart that treatment? So that's the traditional screening algorithm, begins with the RPR, which is a non-TREP test, and then goes to a TREP test, commonly the TPPA for the traditional algorithm. Now, on the other side of this slide is the reverse screening algorithm. And this actually works sort of in reverse of the traditional algorithm. So you begin with a TREP test, often the EIA or CIA. So this very first box at the top should say this is the first TREP test. In the emergency department, that initial TREP test is typically the TPA because that's the one that's run on that same platform, testing platform. So if that initial TREP test, EIA, CIA, TPA, any one of those are run, if that comes back reactive, then at that point you do the RPR or VDRL. And if the RPR is reactive, then you've confirmed that that individual has syphilis, but it's the same as previously, which is you don't know if that syphilis is current or previous syphilis. So again, you need to go back and do a good history and physical exam to see if there's any indication that this is a current case, or if they have a history of previously being diagnosed with syphilis, and then if previously diagnosed, were they appropriately treated at the time. If, on the other hand, that RPR comes back non-reactive, then you need to do one more test, which is a second TREP test, also called TPPA here. And same thing here, if the TREP test is reactive, then you've confirmed that that individual has syphilis. You just don't know if it's previous syphilis or current syphilis, and you need a good history and physical exam to make those determinations. I'll stop there for a moment. It's pretty loaded. I'll tell you that historically we did traditional screening algorithms for syphilis, and then they started noticing that roughly 10% of individuals, and sometimes as much as 30% of individuals, would be missed using the traditional screening algorithm, which is why the reverse algorithm was created. And more labs are doing the reverse algorithm now. Any questions on this before I move on? And again, I recognize this is repetitive. Oops. Sorry, still in the airport here. I recognize that this is repetitive from the community of practice, so please feel free, if you understand all this, to get your other work done at this point. Next slide. Then this is just to talk about how do you handle if you have two different RPRs. How do you know if in fact an individual is reinfected or unresponsive to treatment that maybe has been given to them? And historically, we'll use the fourfold as evidence that someone is either reinfected or adequately treated. So if you have a fourfold increase, that's a sign of reinfection. If you have a fourfold decrease from your initial baseline titer, then that's a sign of that individual being adequately treated. Although many, roughly about 70% of individuals will go back down to non-reactive, we consider that someone's been adequately treated if they have at least a fourfold change. And the best way to recognize if that's adequate is you just divide by 4 from the baseline RPR. So if it's 32, divide by 4, you get 8. If you're looking for a fourfold increase, it's just multiplying that times 4. If in fact you only have a twofold change, particularly a twofold increase, then historically what we will do is we'll repeat that test 2 weeks later to see if it's continuing upward or if that's just a lab error. That may not be possible in the emergency room. So what I recommend you do in those situations, if you have just a twofold change from maybe a previous titer, it's a twofold increase, is again, good history and physical. If that person has been re-exposed, if that person has new signs or symptoms, then I think in the emergency room, it's reasonable to empirically treat those individuals. Any questions on that before we move to the next slide? Okay, so now going to HIV screening. And what's most important about it, HIV screening is that you understand this particular slide, which shows you the course over time in which tests become positive for HIV. So if you look down at the bottom, on the line that starts with 0. 0 is the time in which that individual was exposed to and became infected with syphilis. And initially, there is what is called an eclipse phase. And what happens in the eclipse phase is that HIV remains in the local tissue where that individual was exposed and became infected. And so you can't detect HIV in the body during that initial eclipse phase. I'm going to pause just for a moment. There's a lot of airport talking in the background. Can people hear me okay?
Yes, we can forge ahead. There is a little background noise and we can hear you clearly as well.
Okay, all right, great, sorry. So then after that eclipse phase, which typically lasts around 10 days, then the HIV moves through the local lymphatic tissue and into the systemic circulation, into the blood. And once it's in the blood, it begins to replicate, and it replicates quickly. And so you have this very rapid ramp up phase of viremia, during which the viral load begins to rise very quickly. And so the very first test that actually can become positive in an HIV individual is a HIV viral load. However, most screening tests do not do the viral load first. Just because it's a more costly and time-consuming test, it can't really be done rapidly. So there's, so then the next test that becomes positive is the P24 antigen. And that test becomes positive somewhere between day 10 and 21, once that HIV is broken into the bloodstream and is replicating. And once the viral load hits roughly 10,000, then the P24 antigen becomes positive. And you can see that the P24 antigen then sort of follows a similar pattern as the viral load, at least initially. And so when you're doing the screening algorithm using the antigen antibody test, it's the P24 antigen that you're testing for, and that's going to become positive somewhere between 10 and 21 days post-exposure after someone's been infected, and been exposed and become infected. Then the last test to become positive is the antibody test. And that typically takes somewhere between 4 and 6 weeks to become positive. And so you can see that if you do the antigen antibody test, at 10 to 21 days, the P24 antigen will be positive, but it's going to be 4 to 6 weeks before the antibody test becomes positive. So if you understand this, then you'll understand the HIV algorithms more clearly. So next slide, and any questions about this while we're moving to the slide? Okay. So then recognizing that the first test nowadays that is typically done, especially when you're talking lab-based screening, is the antigen antibody test. Then it makes a little more sense if you follow this sort of simple CDC algorithm. So you start with the antigen antibody test. If that's positive, then what you know is either the antigen test was positive or the antibody test was positive, but you don't know which one was positive with most of the tests. There are some tests out there that are starting to delineate for you which one of those two were positive. But in most cases, you just know you have a positive antigen antibody test, and then you got to figure out which of those tests was positive. So then typically the next test that's done is the antibody differentiation test. So you're trying to figure out, okay, was my antigen antibody test positive because my antibody is positive? And so you run this this antibody differentiation test, which looks for both HIV-1 and HIV-2 antibodies. And you can either have one positive, or you can have two positive, or in very rare circumstances, and this would be much more common in other countries than in the US, you could have 1 and 2 positive. So if your antibody is positive, one of them, whether it's HIV 1 or 2, or 1 and 2, then you know that that individual has been infected for at least 4 to 6 weeks. Could have been much longer than that, but they've been infected for at least 4 to 6 weeks, long enough for that antibody test to turn positive. And so then the next test is to determine what the viral load is on an individual. And in the case that you had both HIV 1 and HIV 2 were negative, then the next test would be a NAT test. I'll tell you, most labs will do the NAT test anyway, because once you know you're antibody positive, you want to make sure that there's detectable viral load there anyway. And so the NAT test is a qualitative viral load. It says either virus is present or virus is not present. And so you can do the HIV 1-2 NAT test, and it will just say, yes, there's virus present, i.e. it's reactive, or it'll say, no, there's no virus present and it's non-reactive. And next. And I just added this because it's some labs are gonna, instead of doing the NAT test, are gonna move right to the quantitative viral load. They're both testing the same thing, but one is a qualitative, where it just tells you whether or not virus is present. The other is a quantitative, where it just tells you how much virus is present. So I added this here just so you know that it might be that your lab goes directly to the quantitative viral load instead of the qualitative NAT viral testing. So this, I'd say, if you understand this, then the rest of the slides, there's multiple algorithms on the CDC website, but the rest of those will make sense if you understand both this slide and the slide before them. I think I have just enough time to walk through those slides and then walk through the Hep C algorithm. So next slide. And next slide. Yeah. So now what these subsequent algorithms tell you is basically which test was done second in a given lab, and then if the antigen antibody test is positive, if the second test is the antibody test, like we just walked through, then the test after that is typically the NAT test. And this is just a more detailed version of the previous slide, because there are either HI1 specific NAT tests or HIV1 and HIV2 combined NAT tests. And they're just going to tell you if it's only HIV1, it can only tell you if there's HIV1 viral load present. And if it's HIV1 and 2, it can tell you which virus is present, if it's positive 1 or 2. Next slide. Now this slide looks at just making the next test the quantitative viral load as opposed to the the qualitative viral load as opposed to the antibody test as being the second test. So in the case that the antigen antibody test is positive, some labs will go right to the qualitative viral load, the NAT testing, to look to see if virus is present. And then typically after a NAT test, if that comes back positive, then the quantitative viral load is done. For this particular one, after you do the NAT test, then the next test is the antibody, because what the NAT tells you is that there's a virus present, but you don't know how long the individual has been infected. And so the antibody test will tell you if the NAT test is positive and the antibody test is negative, then that individual is acutely infected and has been infected for less than 4 to 6 weeks. If the NAT test is positive and the antibody test is positive, then we consider that individual chronically infected, and they've been infected for more than 4 to 6 weeks, but could have been infected for 10, 15 years. Okay, next slide.
Dr. Jacobson, this is Cynthia. I'm just going to note that we have about 5 minutes left and we need a couple minutes to wrap up and we'll do some QA as well.
Yeah, no worries. I think the slide we just passed is just another version of doing the NAT test second. So I think folks understand the concepts, I believe. So we're going to take just 2 minutes to talk through the hepatitis C screening algorithm, where you start with an antibody test, but much like HIV, the first test that becomes positive with Hep C is the Hep C viral load, but we don't have any routine screening tests that screen initially for the viral load. The screening test that's currently available is the Hep C antibody test. So that means that that individual, if the antibody test is positive, has been infected somewhere between at least a month or more, but potentially as long as 6 months. So the first test is the hepatitis C antibody test. If that is non-reactive, then unless you think that individual is at high risk for acute Hep C, then you're done testing that individual. If you think they're at high risk for acute Hep C because maybe they're an injection drug user, maybe they have elevated AST and ALT and you have no other clinical reason for it, then you would want to go ahead and do a viral load on that individual. So right now I'm on the left-hand side of this. So that's if they test negative, but you have high suspicion for acute Hep C. The right side of this is if you do that initial Hep C antibody test and they test positive, then the next test is the viral load. And then if the viral load's negative, then that individual has a history of Hep C infection, but they're no longer infected or infectious. If the viral load's positive, then they're currently infectious and would be an appropriate candidate for treatment if they still have a detectable viral load. And that is as fast as I can do that, Cynthia. I'm happy to answer any last minute questions or can also send questions to me via email and I'm happy to answer them that way. And thank you everyone and apologies for the airport in the background here.
Oh, thank you, Dr. Jacobson. It's heroic to be stepping off a plane and presenting at the exact same time. We all really appreciate that. And I'll just pause here before wrapping up so people have time to digest and ask any questions. Some appreciations here. Okay, I'm seeing appreciations and in the chat. So I'll move on to note the resources that we'll share in the post-webinar wrap-up and that are on the EDSP resources library as well, that you can follow that QR code to reach. On the next slide, I just want to mention a couple next steps. So here's our recap. Developing posters or comm cards, your opt-out scripts, refining those, and your workflows to confirm patient contact information, providing training to all ED staff on syphilis, HIV, and HCV, exploring automated ordering in your EHR system, and building lab processes and using these screening algorithms. And then a reminder to join Community of Practice, our peer-to-peer sharing space. The next one is next week, March 20th, 8 to 9 a.m. I'll just note there's no webinar in April, although we will have the Community of Practice, and then reach out to us as needed. We also really appreciate your feedback on our webinars. We've been able to incorporate some of that. So on the next slide is the QR code, and we'll drop that in the chat as well. And I see that someone hasn't been getting the webinars, so we'll reach out to you directly, and any of you who need to reach out to us, of course, you can reach us at EDSP@bridgetotreatment.org. Thank you all so much for your participation and engagement and the work you're doing, and big thank you to both Ashley for filling in and Dr. Jacobson for joining us in the midst of some travel stress. So we really appreciate you all. Thank you so much.
Thank you, Cynthia. Thank you, Ashley, for pinch hitting for me. Much appreciated. Thanks, everyone.